Welcome to this month's Bariatric Happy Hour. We're so excited to have you all here for another engaging session where we connect, learn, share insights, and all things obesity and metabolic surgery related. I'm your host, Dr. Faiz Shariff, and I'm thrilled to be co-hosting the session along with our awesome Dr. Juyeon Park. So grab your favorite drink, settle in, and let's dive into another insightful conversation. But before we do that, as always, few announcements. ASMBS annual meeting is in June. I hope everyone knows that. The registrations are open, so don't miss your early bird discount. And if you're coming to the ASMBS, then why not get your Be Safe verification and prove your expertise to a credentialing committee? I cannot tell you how important that is at your new job. Now, this is ASMBS and SAGE's joint venture. The other announcements are our fellow project is, as always, on the first Friday of the month. This time it's going to be in April 4th, and we'll be talking about duodenal switch and SADI, so don't miss that. And without further ado, it is my pleasure to introduce you all to our guest speaker, Dr. Joseph Sujka. Dr. Sujka is an associate professor of surgery at the University of South Florida. He went to medical school at St. George's University and did his residency at Orlando Health. He finished his fellowship at University of South Florida, and he is now an MIS foregut surgeon at the same hospital, where he just told us he gets his call rooms because he was a fellow there. He co-directs the Neurogastromotility Center and the SOT Outcomes Research Team. He has particular interest in gastroparesis and related motility disorders, so we'll have to get you back there. And what's impressive is that he has 100 peer-reviewed articles. That is amazing. Our next speaker will be introduced by Dr. Park. Dr. Park, do you want to take it?
All right, so our fellow speaker today is Dr. Matthew Nier. He did his undergrad over at University of Colorado and then did his medical degree at Midwestern University. And he went over to Long Island, which is where I am right now, at Stony Brook University for his general surgery residency. And he is currently at Inova Fairfax Hospital for his MIS Bariatric Surgery Fellowship. All right, Dr. Nier, take it away.
All right, thank you so much. Glad to be here. Let me try to share my PowerPoint. All right, can you all see that? Can you guys see that?
Yeah,
we gave you thumbs up.
Oh, sorry, I couldn't see the video. Thank you.
Oh, okay.
All right, so yes, my name's Matt Nier. I'm a fellow in Northern Virginia and presenting an article here that Dr. Sujka is involved with, so pretty awesome to have him here. Hopefully I don't mess it up too much, but you can let me know. So this is a cost comparison of GLP-1 receptor agonists and bariatric surgery, and what is the break-even point. So a little bit of background. I don't think I have to go into too much detail in the background of the surgeries, a sleeve gastrectomy and Roux-en-Y gastric bypass. But I will do a little bit of history for you guys, and then a little bit on GLP-1 receptor agonists. Yes, that is a butter knife. So bariatric surgery, you guys know, the bypass, we did some experiments in the 60s, and it wasn't widely performed until 80s, 90s. And sleeve gastrectomy was initially part of a staged bariatric procedure, but in the 2000s became a highly effective standalone procedure. As far as costs, though, they have changed pretty dramatically over time. I couldn't really find any cost numbers in the 70s and 80s, but in the 90s, as laparoscopic techniques were evolved, recovery times and complications came with it, and costs were pretty high. So often exceeding $30,000 per procedure, especially without insurance coverage, because it was a relatively new procedure. In the 2000s, the surgery became a little more common, cost stabilized, and were anywhere from about $15,000 to $35,000, depending on the procedure, hospital, insurance coverage. They were starting to cover around this time. And then from about 2010s until present, as we refined our techniques and they became more common and widely accepted, the averages have stabilized. Usually it's like the numbers are between about 15,000 and 25,000, depending on what papers you read. So this does not include all the pre-op and post-operative costs, really just the cost of the perioperative period and the surgery itself. GLP-1 receptor agonists, so just a little microbiology, our favorite, and the reason why we became surgeons. So GLP-1 is created by L cells. It's in the distal small bowel, the ileum, and the colon, and they're stored in these L cells. And anytime we eat or even think about food, especially carbs and fats, when we eat those things, neural signals are sent to these cells and they're released. The GLP-1 is released. So these GLP-1 receptor agonists, they work by mimicking GLP-1. And it overall does all of these things and more, as you can see in the photo here. Enhanced insulin secretion, glucagon secretion, or reduced glucagon secretion, delayed gastric emptying, and appetite suppression. So GLP-1 receptor agonists, or GLP-1s, were actually developed in like the 80s. And in the 80s, or like late 80s, 90s, GLP-1 receptor agonists, the first one that was FDA approved was actually in 2005. It was called Byetta, exenatide. And costs back then were about $200 to $300 per month. Still pretty expensive, but relatively cheap compared to what they're charging now. In the 2010s, there were new longer acting GLP-1s like Victoza or liraglutide and Trulicity, dulaglutide, which were around $500 to $800 per month. And these were all primarily for diabetes management. And then we had this obesity treatment cost surge in 2021. So that's with Saxenda, Wegovy, and now we have Zepbound. So all of these new FDA approved medications, a couple of which are approved for weight loss. And so prices skyrocketed, $1,000 to about $1,400 per month for these medications. So the goal of this study was to compare the cost of these medications to bariatric surgery. And then the results of this study will help us as providers make decisions between between surgery and medication. So have this shared decision model with our patients on what is the best route for them. So methods, we took Roux-en-Y gastric bypass and sleeve, looked at the prices from the 2015 Premier database, and adjusted the price for inflation using this calculator. And I'll get to the prices in a couple of slides. The FDA-approved GLP-1 agonists, Wegovy and Saxenda, were included, as well as some off-label medications that are still commonly used for weight loss. They looked at the GoodRx retail pricing for GLP-1s in 2023, the average costs nationally for patients, and then verified these costs with the 1 month supply costs on Hippocrates. So here are our numbers. So in 2015, a sleeve was around $11,000. Adjustment for inflation was around $15,000. In 2015, a bypass around 14,000, adjustment for inflation, that's hard to say fast, is around $18,000. And then you can see in the table here on the right, brand name, generic name of the weight loss of the GLP-1 agonists and their average monthly cost here on the right. So the average cost amongst all of them was around $1,300 per month, standard deviation of $275. And this graph is a little bit blurry, I apologize, but this is a plot of the cost of a sleeve, that's this dotted line down here, and a bypass as a lump sum, so around 15,000, 18,000 here. And then the cost of each of these GLP-1 agonists plotted over the course of many years. And so the goal of this study, or what they wanted to look at, was at what point, how many months does it take cumulative costs of these medications until you reach the point where you're paying as much as a sleeve or as much as a bypass. And if you continue these medications, how the costs look compared to both bypass and sleeve. So at what time frame do we reach that with each of the medications? And here's a table that summarizes that. So Wegovy, being the most expensive, takes about 9 months to cost the same as it would to have a sleeve gastrectomy, and about 10.7 months to cost the same as it would to have a bypass, and so on. So a few points from the discussion of this article is that surgery is cost effective for obesity compared to these medications, especially if someone is on them for longer than that time period. It doesn't really dive into the reduction in total medication costs, but this is very important when it comes to surgery, is that over time, people's medication costs go down dramatically and saves time over the long run, or saves money over the long run. And then, yes, you could take GLP-1s for less than a year, and it could cost less than a surgery. But then if you're done with that medication for a year, you can regain weight, and then you're still paying for the medications that you're currently taking for your comorbidities. One other point that they made is that GLP-1s take time. So they take a couple of months to reach that steady state. So this delays onset, delays weight loss, and you're accruing these costs over that time period. So surgery, they do talk about some potential operative or post-operative complications and what these could cost the patient or the healthcare system. So after a sleeve in this upper table and bypass, the risk of bleeding is 1.5%. And if you do have that bleeding, could cost around $6,700. Vascular compromise, $3,200, a pulmonary complication, $7,600. Same down here for bypass, bleeding, a little bit more, anastomotic leak, and pulmonary complication. So some substantial costs there. The paper did not talk about this, but I thought I would bring it up, there are also complications of GLP-1 inhibitor or agonists. And while they're rare, just like the complications from bariatric surgery, I think it's important to talk about them, which pancreatitis is a potential complication rate. It's pretty low, less than 1%, but you could have ER costs and workup, admission costs and workup and treatment, which would cost thousands, if not tens of thousands of dollars. Gallstones and, biliary colic or cholecystitis or cholangitis, whatever it may be, or you're going to have to work the patient up for all those with tests and everything. So AKI, thyroid tumors, hypoglycemia, also some potential complications of these. So I figured if we talk about some complications, potential complications of surgery, might as well talk about potential complications of GLP-1s. Limitations of the study, which they had a nice section on this to discuss these, is that they did not consider the efficacy of each option. So that's like, obviously a weight loss medication does not have as much weight loss as surgery. So if you would really like to compare the costs, you should do it like price per pound loss or price per percent total body weight loss. This does not reflect the individual situation. So not everyone is paying an upfront cost, or they can have insurance cover a lot of these medications or the surgery. So they did not discuss any of that, and then does not account for any associated costs after the surgery or starting the medication. So nutritional deficiencies or follow-up appointments and testing. So conclusions, GLP-1s are cheaper at first, but cumulative costs reach the same cost as a bariatric surgery at 1 to 1.5 years. GLP-1s have a delay in results compared to bariatric surgery and weight regain when they're stopped. So overall, this makes them a lot less cost effective. And from what I've learned, and I'm still trying to learn as a fellow, and I definitely did not learn as a resident, is that in real life, it's all about, unfortunately, money and return on investment. And when it comes to getting things approved with insurance and what the hospital wants and what you can get when you're asking for things, all has to do with return on investment. And so I think that it's one thing to tell them that medication probably won't work, but if we can show them the actual cost breakdown of these medications, what they're going to end up spending over time for these medications, maybe they would be more willing to do surgery. And I think this is also really important to discuss with primary care teams that are prescribing these medications and seeing obese patients. They should be aware of these costs so that when they're thinking about prescribing them, maybe they should also consider referring to a bariatric surgeon. So, and this is just one additional slide. I actually did a lecture with my program earlier this year about the economics of bariatric surgery, and this was a graph that I made. And it's kind of similar, but it's comparing the cost of a surgery and post-operative costs to not having a surgery and all of the payments or medication costs and hospital visits and procedures, interventions that you would have over the course of 30 years if you didn't have that bariatric surgery and lose weight. And that costs well over $500,000 compared to suspected under $100,000 if you had a bariatric surgery and your comorbidities resolved. So
that's very interesting. Are you publishing this?
No. It was just it was just based on some research I did. I think that's out there in the public. But this was just a graph I made based on that.
Very interesting.
Yeah. So I don't know if I could ask a question to Dr. Sujka.
Yeah, this is all interactive, anyone can ask
Absolutely.
a question anytime.
Awesome. So I wrote this down. So given your findings, what policy recommendations would you suggest for insurance companies or healthcare policymakers? Like, should they prioritize bariatric surgery to reduce these long-term costs, or do you see a role for GLP-1s in like this intermediate step before surgery?
Absolutely. I think that's a very good question. First, before I jump into it, I want to say thank you very much for that summary of the paper. And then also thanks to Dr. Shariff and Park for having me here today. I think that is a multifaceted answer. I think that it depends on who you're asking to benefit, right? If you're asking to benefit the patient, then ultimately we should be looking at what's the most cost-effective way to make them healthy over a long period of time. And I would argue that bariatric surgery time and time again has shown superiority to medication. But if you're talking about shareholders of Novo Nordisk, Pfizer, and other companies, they do not want us to do surgery, right? They want to make money on their medications. and they're going to do everything they can to make sure they're easily accessible and expensive as time goes on. So it truly depends on who you want to benefit. I think that this paper is important because you need to know what it costs. And I think that it's all too difficult in the United States to say what something costs. And a lot of the critiques of this paper was, well, you didn't take into account this, you didn't take into account that. But ultimately, to make it a very fair argument, we wanted to keep it very basic. Because at the end of the day, you can argue any gray area here. From a policy-making standpoint, we need to improve the ability of the patient to have the access to bariatric surgery, because ultimately less than 1% of patients who actually can get bariatric surgery do or have coverage. And the fact that it's so difficult to get people to have their surgery covered is a crime, because ultimately we know that this works. And we've been fighting against both insurance as well as what people think bariatric surgery is for years. So I would turn it around back at you and say, how do we get these policymakers to see it our way and see it that this is important and that ultimately we should be offering patients the full gamut of treatment, not the thing that makes people the most money?
Yeah, that's true. I mean, it's you have to show them the costs, like exactly what you said and what you're doing with this. And it's the raw costs and not including all these other factors into it. But I think that is important.
And then on top of that, we have to examine all the same things, right? You know, we talk about safety of bariatric surgery. We talk about cost. We talk about complications. Nobody can really tell you what happens when you take a GLP-1. Do they end up in the ER more often or less often, bariatric surgery patients? I don't know. But we're looking at it here because we have about 11 years worth of data for these medications at our institution. And at the end of the day, I would suspect that maybe they have a little bit of a less ER visit rate because we keep our patients out of the ER. But ultimately, that it's important to know these things. And I think that we're just at the beginning of that understanding. And to a certain extent, I think that this will all even out with time. I think that a more nuanced understanding of where these medications fit into our treatment algorithm is incredibly important and will ultimately only come with time and examination of the data.
Awesome. So Dr. Sujka, now it's your turn to kind of enlighten us a little bit more. And then I think I have a whole list of questions. I didn't want to ask them now because maybe you're going to cover them a little later.
Absolutely. So we kind of hit some of the high points that I already wanted to put in here. But ultimately, this paper gestated from examining our own fear of these medications and trying to analyze where we are with them. I think that where we are with them now is going to be very different than we are in 5 years. But I think that a frank examination of cost is tremendously important. But when you're talking about cost, something we didn't really touch on in our presentation is that bariatric surgery also has a rate of recidivism in their weight gain. And that ultimately, that's something that we have to be honest with patients about. In our practice, at least, we have a medical bariatrician. We have 2 of them, actually, both of which will see patients depending on their preference. But they tend to see our surgeons first and have a conversation about what surgery is. And we are sort of the face of our group. At the end of the day, we tell people, hey, this is what surgery looks like. This is what we're offering. These are the options we have in clinic. And we have the whole gamut from robotic to laparoscopic to endoscopic surgery options, including medical weight loss as an additional arm of our group. And I think something that we've done very well is incorporate that into our practice and not try and get it away from us. Because to a certain extent, as time goes on, we're going to find that this is a very important thing for us to have, not only for patients who have not had bariatric surgery, but both after bariatric surgery. We've been looking at an algorithmic approach to weight recidivism that includes these medications, because endoscopic and revisional bariatric surgeries also have their own issues. And ultimately, we need to give patients as many options as possible, just like when you have any sort of procedure. If you have heart problems, not everybody's getting an open heart surgery, right? People are getting endovascular procedures. They're getting medical procedures. They're getting weight loss and exercise. And I think that bariatrics is at a turning point where we will incorporate this. And I think that ultimately, we will be providing excellent patient care by doing so.
Thank
I try
you.
not to talk very long.
No, thank you. That's awesome. So now, my whole question, or when I first read your paper, if we are going to pivot and kind of base talks based on cost alone, then I think that's not going to be. It's a dynamic process, right? the cost of one thing goes up, the cost of others coming in with the newer GLP-1s coming into the market, do you actually see that the break-even point might shift? And if you look at Mounjaro was recently introduced in India, it only costs $200 when you compare it to here. So if we are going to, I mean, basically what I'm trying to say is, do you anticipate, one, the cost of these medications to come down? And if it comes down, how does the conversation change based on that?
I suspect, based on Dr. Nier's slides, that these medication costs will be fairly stable for a long period of time, because that's the way that our country works with medications. You know, my dad was a urologist, so a lot of what I know is sort of related to medications that are related to erectile dysfunction. And when Viagra came out, it was expensive, right? It stayed expensive. And then when the patent was about to run out, they used Viagra or sildenafil citrate as a pulmonary hypertensive agent in the ER and the ICU to make it more expensive. So I think that unfortunately our healthcare system is designed as such to not make prices go down, as evidenced by our recent government interventions where they're supposed to be medications that are less expensive, like insulin. And ultimately, that's not something that's come to pass. Those medications have not become cheaper. At the end of the day, I think that unfortunately our insurance situation makes it very difficult to say what these things are going to cost in the future, because coverage varies widely. That's why I think that at least this as an opening salvo is important, because I think that what people have found over time, fad diets, different diets that they do, exercise regimes, is that the weight loss boomerang is a very real thing. And I think that right now people see these medications as an easy win to lose weight, but are losing the forest for the trees in their understanding that ultimately a lot of this weight is going to come back without lifestyle changes or additional more permanent interventions. And I think that what we should be talking about more so than cost is effect over time. You know, I know as well as everybody else that I don't want to take any more pills in the morning. Every time I add more pills, it drives me nuts. But at the end of the day, we need to be talking to patients about this is a medication that if you start, you will probably need to stay on, period.
Yeah.
And it doesn't matter what the cost is. Ultimately, it's going to be a long time that you're on these medications, and they may or may not be effective. So I think that the focus for it needs to be lifelong versus an intervention that you can put behind you.
Awesome. We do have a question in the chat. It's Dr. Neff. He asked, do you think that we need to change our messaging as bariatric surgeons and stop competing with GLP-1s, but start to recognize that this is another tool in our toolbox for management of patients suffering from the disease of obesity? Just like breast cancer patient needs surgery, chemotherapy, so does bariatric. And I actually, I do have a conversation like this with my patients. When I say, you know, when you're looking at obesity, think of it as a disease, just like cancer, right? So I think, I mean, the question's for you, but I do feel very passionately that we should be kind of incorporating GLP-1s into our practices too.
Absolutely. And I think what makes it challenging is that a lot of us went into surgery to avoid this, right? We didn't want to follow all the medications. We didn't want to follow all the treatment changes. We like doing our surgeries and getting patients better. And I think that unfortunately, a lot of diseases are getting to a point where we have to have more of an understanding than we ever have before with mechanistic actions for treatment. Just as an example, I treat a lot of gastroparesis patients. I have to know all the neuromodulators. I have to know all the antiemetics. I need to know all the promotility agents. And I find that fun, but I also recognize that I'm a little weird. At the end of the day, most people don't want to be treating gastroparesis patients at all. But I think that we have to open our minds to this and say, this is something that we need to know about and we need to take control of, because otherwise it's going to be primary cares and medical bariatricians making these decisions for patients. And as we've seen in the past, primary care does not do a good job of getting obese patients the care they need. They don't refer them to bariatric surgery. They don't treat them the way that they should. And we need to be getting out there and getting our certifications for medications, understanding how they're done, advertising that we do them, helping patients get these medications, because the only thing that does is help us be better physicians for them.
Good. And just to add to that, when you talk about primary care, right, primary care doctors have exactly 10 to 15 minutes. And that's something that we were talking in our health system as to how to integrate this and develop a comprehensive program. And when I first met with the the CMO of primary care, he's like, how do you anticipate or how do you expect us to bring in obesity? It takes me 45 minutes to talk about obesity, but my first visit, right? So I think, and let me know what your thoughts are. I think the role for PCP should be like how it is for other cancers. The role is screening and then recognizing recurrences. So screening like mammogram. The moment you say mammogram, the prime PCP doesn't have to explain everything. He just has to say, you're due for your mammogram. Same thing. So, if you have some sort of a way of recognizing patients with obesity, not just based on BMI, but on the comorbidities, they say, hey, listen, I think you have a problem. Why don't you go see an expert, right? And then once we have taken care of them, they can go back to the PCPs. So what do you think?
I think that is helped when we're doing the medications as well.
100%.
At the end of the day, when they come to see us, I think that the fear of surgery is very strong. Anybody who hasn't had surgery or works in surgery or is in the healthcare field thinks that surgery is scary. And at the end of the day, I think that we need to be gatekeepers of this because we are the ones who understand it. When we see patients, if you say to somebody, I'm going to send you to a surgeon, they're not going to go a lot of the time, right? If you say you're going to send somebody to a bariatric clinic that has multiple options, that makes it a more welcoming location. And ultimately, when you have more for patients, they're going to be more likely to come. And it'll also make it less threatening to the primary care because the worst thing that they see is somebody goes and has surgery and either has a complication or comes back and isn't any better. That's the last thing primary cares want because they want their patients to get the best too. And so if you have something that's just a bariatric clinic, not just a surgeon, not just a medical bariatric weight loss person, not a dietitian or a psychologist or an exercise person, having something that is total makes it a much better place.
Good. So then my question is to you, why then do we have only 1% of patients coming to us? When we think about the rate of obesity and severe obesity, it's just climbing and climbing, right? I guess in the last 2 years, it has stabilized a little bit, but we're talking in 40% of Americans. So, and then when you look at FASMBS numbers for surgery, it doesn't go up. What do you think the reason is?
I think that a lot of it comes down to fear, but also options. At the end of the day, the medications we've had for medical weight loss for a long time have been relatively ineffective and relatively high in side effects. So the medications that people were previously receiving had a lot in the way of cardiac side effects and long-term issues with their efficacy, with poor weight loss. But now we're seeing this thing just walk into the arena and say, hey, look, I can help, and it's not just surgery. I think that notoriously primary cares are hesitant to send people to surgery because they think that everybody's going to get a surgery. And I think that it comes down to when you have a more holistic view of treatment of patients that they will come in. I think that referral patterns for bariatrics are very difficult because of the fact that insurance is very variable. We have a very hard time in Florida because we have hundreds of insurance companies and very few of them have primary and then revisional bariatric privileges. And so the first thing we do, I'm sure as everybody else does, is run their benefits and make sure that they have it. And if they don't, then we're sort of out of luck. We don't get to even treat them. They don't even come in the door for a lot of our practices. But if you have somebody come to your clinic now and you can run their benefits and they might not have surgery, but they have the ability to get medications and for you to still help them, that's not a closed door. And I think that for a long time, insurance and payments and patient fear has acted as a door closing us off to more patients being able to see us because we're passionate about wanting to get people better and how live a better life. But it's hard unless they meet us to know that.
Dr. Park, do you want to ask any questions? I know you had a list.
Yeah, sorry, I had to run away for a trauma alert for a second, so I don't know if I missed any big questions. But my question is, I think you guys might have already talked about it, but you guys do prescribe your own medications at this point or no?
Right now, we have medical bariatricians in our clinic. We have two of them, one who trained at Emory and one who is one of the first, I think, 3 medical doctors in the country to get a bariatric certification. So she's been here a minute. And we have conversations with them routinely about what's going on in our practice because they are a part of our group. We have discussed going out and getting the certification for medical weight loss, but the way our practice is set up is that typically our patients see us and then they get referred on to medical weight loss or stay in our group depending on what their preference is. So we do not prescribe them ourselves because we have an excellent group in-house already, but it has been something we have discussed. And if I wasn't in a scenario like that, I would have already gotten my certification to have it so I could use it as part of my group.
Gotcha. And what is the
Wow.
process that you guys have of like getting the patients back from medical weight loss? Because like
So,
the only patients I've been getting are medical weight loss, and I keep giving it to my bariatricians, and I'm like, are they coming back? Are they not?
I
A lot
think
of that comes down to the education beforehand. And sorry, Dr. Shariff, I think you want to jump on and say
no.
something.
I was just going to say, answering to your first question about whether do I prescribe, yes, I do. What we have seen, I do only purely bariatrics and a little bit of foregut, but so we don't have the gastroparesis clinic and others to fill up. So our volume dropped. And then what we saw was the volume drop by 30% from what we normally see. And then if you look at the medical side of things, the number went up. So clearly people were looking to get medications. And if you kind of break down the demographics, a lot of patients were going for medications with real high BMI ones. And we know GLP-1s are not as effective for those real high BMI ones. And what we then did was we said, the surgeons are going to see these patients, and instead of calling ourselves surgeons, we call ourselves obesity specialists, which we technically are, right? And what I do in my practice is I keep them, if they're hesitant to go for surgery, the first step, I keep them on medications for a year. And in a year, some will have some weight loss, but not enough, and some won't. So, and then that way you can get them back. So I would kind of, even if you're sending them to your medical weight management people, have some sort of a mechanism of seeing them again. Say, hey, I'll see you in 6 months or a year time, right? And let's revisit. We don't have to talk about surgery. Let's see how you're doing.
And
Sorry.
a lot of it is messaging, right? Like initially when these medications came out, our medical bariatricians were going out to PCPs and saying, look what I can do, right? And so we had to sort of sit down with them and say, that's fine, look what you can do. But also we're a group, right? We need to make sure we're all on the same page. I think there's sort of two ways of thinking about it. One is what Dr. Shariff said about we need to kind of check in with our patients. But I think about it a little bit differently. I think about medical bariatricians as a bank with accruing interest. Ultimately, you send people to them, you feed them, and they will feed you back. So when patients can't afford medication anymore, they have a side effect, they don't want to be on medications anymore, the people they send will be back to you. Because if you feed them, they're going to feed you. And so at the end of the day, I send patients all the time to medical weight loss for hernia surgery because I do big abdominal wall stuff. I do, just bread and butter ventrals too. But ultimately, I send them there and I say, hey, can you help this guy lose weight? My goal BMI is 35, whatever it is for that case. And then what happens? And when they hit 35, I get an email, hey, your patient's ready for you. I'm sending them back to you. So I always think of it as medical bariatricians as sort of, again, a bank with accruing interest. As time goes on, you feeding them will end up them feeding back to you. It's not like you're going to send them a patient, and then as soon as they're not doing well on medications, they're going to send them somewhere else, right? They're going to say, oh, Dr. Park's in this patient. I'm going to send them back to them. And that's what's going to happen is we're going to have these patients who are 35, 34, 40-year-old patients with high BMIs who go and lose weight. They feel a little better. They come off the medication. Then they gain their weight back, and they're back on the medication. And ultimately, they're going to say, where's my permanent solution? And that's when they'll come back. And that's when they're also really set for surgery, because at that point, they've already gone through the ringer. They've already seen diet. They've already seen psych. They've already seen the medical bariatrician. If they have cardiac problems, they've probably seen them too. And at the end of the day, I think they're actually in better shape for surgery at that point because they have lost weight and made some positive changes rather than walking through the door at the very beginning.
I actually want to ask all our fellows listening in the chat box if you guys can type this in and let us know how many of you are looking to actually get the ABOM, the obesity medicine certification.
I signed up, I did it.
Okay, we'll give them some time. Let's see.
I'm hoping that
I
after this
just
talk,
saw
more of
some
them will
hands.
consider it.
The problem is I don't know how to see this. I see one hand being raised. Okay. All right. So we'll see that. I just think it's a good idea. I mean, like you said, we don't have the luxury of saying, this is what I do in the operating room, right? Like you need to understand the disease process and you need to understand, you got to be the strongest advocate. I think the biggest problem with obesity is the stigma that comes with obesity. How many times have you met people in your hospital healthcare system where they say, oh, you're just providing them with the easy option? Or, the kind of stuff that's been said to us, imagine what's being said to the patients. So if we
Or
don't
my
understand,
least favorite when they say you're not helping those people. That's my least favorite. And I hear that all the time about gastroparesis patients too. They say you're not helping that person. They're crazy. What are you doing? Start operating on that. You're nuts. I'm like, well, you might have that opinion, but that's a stigma that you're carrying with you and is incorrect.
Yeah. I guess when we don't understand a problem, we just say it's not a problem.
I would not disagree.
Right. What is next for you in terms of are we looking for a part 2 of this?
We have a couple of different studies in the pipeline. Right now, we're going to look, I think, at our 11-year data and look at ER visits as our next step, because I think it's an appropriate comparison to say if you have surgery, what's your rate of ER visit versus these medications. We're also looking at a pre and post operative algorithm for use of these medications for surgery patients, to basically formalize what does it mean to take these medications around the time of surgery. And then something else that I wanted to look at was specifically what's the dose response of medications for BMI versus drug. Because I think that ultimately we talk a lot about, rate of weight loss, excess versus total body weight loss. What does surgery do? But I don't think we have the best information when it comes to how do we select these medications for people. A lot of it is based on what's available, what's cost effective, what's covered by insurance. But not all medications are created equally, just like how all muscle relaxants are created equally. They all work a little bit differently. And I feel very strongly that as time goes on, we'll have a better sense of which of these is best for which of the situations and ultimately be able to make that decision better. So we have a lot rolling around all the time. We have a big data science lab and a med student lab. And so we're always working on something.
Yeah. Dr. Nier, do you have any questions you want to ask?
No, you asked my other 2 questions I have written down here.
Which one?
Question that I've been thinking about in clinic is just, how we always talk about the fact that for patients who have very high BMIs, like 40, 50, that the medications do not work. I've been getting patients who are in their BMIs 40s, 50s, and they say they want to try the medications first. Do you just let them try it? Is it actually going to work? Do we have data actually saying that it's not as efficacious?
I think that data is lacking, and that's why I want to look at our data, because we have that period of time for so many years that we should be able to make a case for that. I suspect that more than likely over a certain BMI, medications aren't very effective. I think that there is an underlying reason for that I don't think we know. But at the end of the day, I don't think there's anything lost by having them try. If they do have a BMI of 40 or 50 and they get down to 45 or 40 or 39, all the better for when they eventually have surgery, because they will have a better functional status by that point. But I caution people that medications are not a silver bullet. I saw a patient today who wants me to do his 5th ventral hernia repair with a BMI of 48. No thanks yet, but we'll get him there. And he has been on Zepbound for 4 months and has lost 4 pounds. So, that's not very good return on investment. And he knows that. He's working on it. But at the end of the day, I think we're going to know more in the next couple of years about how does this work, who's the best person for it. And I think that once that gets to that point, we'll be able to also make a point of who should have surgery and who shouldn't. And once we have that data, it'll be time to move forward a bit.
Okay, so a question for from the future. I was at one of these conferences, and then I was told that there are 22 other medications in the pipeline. So that is going to bring cost down, and then there is a triple agonist that's going to be as effective as surgery. What's your take on this, and do you really think this is going to disrupt our field?
So I'm going to make an admission here publicly.
Okay.
I've taken Ozempic. I've tried it. My wife was on it for a while. I lost a couple of pounds off of it. It was not a fun medication to be on, ultimately.
Tell us more.
Well, so the nausea and vomiting is tough initially. Bowel function becomes challenging. And eating is a lot of fun. I'm going to be totally honest with you. When you can't eat because you're sick, it's not a very good feeling. I cannot imagine taking 3 of these medications at once. At this point, I think that they are effective, but I have a hard time believing that more is better, because we know that as people are on these medications, they become less effective over time. That's why doses have to go up over time. And if you're telling me you want me to be on 3 of them all at once, I don't think that's going to go over very well. I think people will try it because people are absolutely going to try medications, but I do not think that over time people are going to want to be on these. You know, they've shown that as time goes on, emptying gets back to normal, ultimately function improves, but you're still hungry and it doesn't stop you. And the medications have to go up and up and up and up. And over time, eventually they just lose their effect. There is a top point. And I used to have a colorectal surgeon who looked at me and said, Joe, you are 1 medication away from being obsolete.
That's, oh my God, how many people have said that to
He
us?
used to say that to me all the time.
All the
And
time.
now that we have seen this, we know it's not true, but ultimately it's a narrative that has to play out and run its course.
I mean, that's true. It's just like cardiothoracic surgery, right? If this cardiothoracic surgeon had taken control of the narrative in terms of interventional cardiology, I don't think it would have been that dramatic. But even with that, we have cardiothoracic surgeons. They run an OR every single day. You know,
and not only that, it's one of the most competitive fellowships in the nation now because they didn't make enough of them.
That's true. I feel like that's something that that's going to happen. So all the bariatrics fellows out there, don't be worried. It's not that we're going to be out of job. I truly, truly believe that, you know, you're just seeing a small slump and it's going to come back.
Yeah.
Now, in the meantime, while we're going through the slump, any advice for our new fellows here on how to sustain yourself? Because I think I'm sure a lot of our fellows here are worried about that. It's not easy to build a bariatric practice anymore.
I would say that it's difficult. You have to say to yourself that you want to do it, right? You're in this fellowship for a reason. You enjoy this. You want to do this. You have to find ways to use your tools. At the end of the day, I always think it's important to be interested and well-read. So I would challenge you to look around and see what your skill set can offer to other people. Most of what I do in bariatrics right now is actually not bread and butter bariatrics. It's actually revisional work. I do most of the time revisional and endoscopic stuff. But that's not because of GLP-1s. It's because I find it challenging and interesting. But that also completely moves into my also enjoyment of foregut and gastroparesis and other interesting disease processes. And that interest in gastroparesis is also, full circle, led me back to interest in bariatrics. I used to have an anesthesiologist who said that if you find something that no one else is interested in, you'll have immediate work and you will have immediate interesting research topics. So he always encouraged me to find things that I found joy in and not just finding one specific thing to point myself into. So maybe you don't find a place that's 100% bariatrics. Maybe you don't find a place that is exactly what you're looking for. But that doesn't mean that you can't do interesting things and build that up yourself. And I do think that as time goes on, it is going to swing back the other way to a certain extent, because people don't like being on medications for long term. People don't like spending a lot of money for no reason. And I think that eventually we will swing back the other way. I would just encourage you to stay interested and to read broadly and to see what else out there interests you.
True, because I also heard of this argument that, after the invention of PPIs, we don't see peptic ulcer disease. Now, my argument to that is that peptic ulcer disease comes down to the last step, right? The proton pump inhibitor. Now, can anyone tell me what is the last step for obesity? I don't think anyone of us know about that. I mean, as of now, we know 23 genes are involved, and God knows how many other hormones are involved. So personally, I don't think it's going to be obsolete. Like you just said, it's just going to go through this dip and then it's going to come back, because Last year, we saw a big decline in our number, and now most of my patients have been on medications. They either come back because of the cost, they come back because of the complications, they come back because they want a permanent solution in their head. Now, it's important for us to remember and tell them that it's not a permanent solution. This is a chronic disease, but yeah.
And I also think that, at least for me, I love interventional endoscopy. I think it's fun. I think that we are uniquely positioned to do a lot of cool things endoscopically. And I think that's something that we need to pick up the ball with and run with. Here at my institution, we have completely bogarted endoscopic suturing and POEMs and endoscopic third phase surgery and stents and endovacs. We do it here. That's our job. And that's because we have taken that and basically boxed out the GI service. We have excellent interventional GIs who really want to do those cases, but we're not giving it up because it's our cases. And I think that those are other things that you can get involved with and enjoy and do and be perfectly primed to do anything else in the bariatric surgery world, including revisional work.
True. And another thing is, just to your point, now if you're going to be offering these services, right? Like if you do a gallbladder on a high BMI patient, actually I have a story. A patient was referred to me from a different hospital. I forget what her BMI was, but it was high 60s or something. And surgeons didn't want to touch us to take out a gallbladder. And this poor lady has acute cholecystitis, and she's here, and I go and take it out, and then she comes and sees me in the post-op visit. Now, obviously, I cannot resist a good conversation on what obesity is. I mean, that is my passion. So I'm going to sit and talk to you. I don't have to see her 4-incision to see it's all fine, right? So I start talking to her about this, and I help her understand what obesity is, and give her much, the speech spiel that I have. And I said, listen, I'm going to explain to you all the options. You don't have to decide today. Go think about it. Come back. So she came back 4 months later, and she went through the process. She's a SADI patient, and she actually has become an advocate for obesity. So she posts on Instagram. So if you're on Instagram, you'll see that. No, but that's important. I think putting up from work, obesity, you got to feel passionately about this subject. I think a lot of surgeons got into bariatrics because it was lucrative. I mean, it still is, right? But I think you got to have do it for the right reasons, and then slowly build your practice. Patients aren't going anywhere. 40%, guys, 40%. See, the difference between cardiothoracic and us is like if someone had a heart attack, they were coming to the doctor. They were not sitting at home. Our patients, they sit at home.
That's true. That's very true. And, honestly, I think that speaking to your point about obesity patients and referrals, I think that when we get calls for patients like that, sort of a nice compliment. It says, hey, I don't think I can do this case. Why don't you do it? Our trauma service occasionally calls me for sort of random consults, right? And about 4 weeks ago, they said, hey, we have this morbid obesity patient with a splenic abscess. Can you do her splenectomy through little incisions? And I'm in my soul a general surgeon. So I said, sure, no problem. Took it out, small incisions. She went home the next day. I saw her in clinic. She's doing great. But that was like the biggest compliment that the trauma service is calling me on this obese patient to say, hey, can you take care of this? And absolutely, this is what I trained to do.
Sometimes I get some more random one. Like we have an ECMO program in our hospital, right? So I get this call from pulmonary critical care, and I'm like, I don't have a patient there. And then you start worrying, oh my God, who got a pulmonary embolism?
What happened, right?
I know, like who is the one who has a PE? He calls and says, hey, Faiz, do you by any chance, would you consider doing an emergency sleeve? Again, another opportunity for you to say, hey, listen, how about me coming and giving you grand rounds here and talk about this?
Oh, yeah. We do them in transplant patients here. We do them as part of when we do livers. We'll actually do them in people who are on ECMO. We'll do them on people who have cardiac assist devices. Because all of these things, while higher risk, are ultimately something that we can offer to those patients that will make their outcomes better. And on those people who have cardiac assist device or ECMO, our goal is to get them a transplant. But our transplant surgeons are like, if you are 35.01, you're not on the list, right? They have to get below that number. And so we're talking about their life, their future. And so, we're involved in everything around here. And I think that to a certain extent, bariatrics has done a fantastic job at being safe And I think right now we have to be a little bit more agile on our feet to see what else can we do, what else can we get involved in and show value, with the understanding that it might not be the same bread and butter cases that we're used to. But ultimately, we have a skill set that can still help lots of people, and I don't think this is for long where those numbers dip.
Okay, one more question, since we have 5 more minutes. Not letting you go 1 minute.
And I don't want to go back to fellow interviews. I'll be totally honest with you. Our fellow interviews are going on right now. I'm going to go do the checkout at the end.
Okay. Are there any, to your knowledge, are there any comparative studies or any plans for comparative studies on patient satisfaction, quality of life, and mental health outcomes after the 2 interventions?
We are looking at quality of life. I don't know about psychology, but we have every single patient see a psychologist, so we could probably check that. I've been trying to get the psychology team to use a unified survey for a while now, so we can sort of track patients over time. But we are definitely
looking for your medical patients too. Sorry, I didn't know.
Yeah, we do. We actually, Dr. Yost, our person who came from Emory, is working with our EPIC team to have a unified survey that gives people the GERD HRQL score, the quality of life survey, and then I think there's one about anxiety and depression to every patient who comes to the door for our bariatric clinic. So the goal is to have that, but right now we're working on quality of life measure. I just don't know that we have it yet.
Okay. So, or would you recommend that, like patients who are going to be on these medications, kind of like, when you look at their surgery, it's not just the surgeon, right? Like you get the help from your psychologist, you get help from your dietitians, but there are 2 problems with medical weight management. If you look at one is it doesn't reimburse well, and hence that you don't have infrastructure at most places to have all of these things taken into account. But you guys do that, and you would advocate for that.
I would, personally. I think that it's very valuable. Not everybody's going to have that. Our clinic is very well worn at this point. We've had these resources for a long time. But sometimes you have to look out in your community for people who can see them and can afford to see them and spend their time with them. We've been very lucky here in that our hospital has continued to support us throughout all of this, and our volumes have been pretty good still. But it takes time and effort to build a clinic like this, and sometimes you have to build sort of a hodgepodge group around you of people who you can send them to and have them be seen by and taken care of.
Okay. Last question, coming back to your paper, because that's where we started from. Now, when you were looking at this, the cost comparisons, did you break it down by socioeconomic status? Or was there any way you could have done that? Because it would be interesting to see how higher socioeconomic status patients, what their treatment, the treatment they're receiving, as opposed to, say, lower socioeconomic status patients.
Yeah, we didn't look at it here, but there's been 2 studies in the last 3 years that have been interesting. One's the Barry Hood's study that was through SWORD. And then we actually published a paper in the Journal of Surgical Research that looked at zip codes and Feed America data and whether or not weight loss outcomes were different based on zip code. And when you look at Feed America data, which is when you have food insecurity, the bariatric weight loss was actually less in people who are more food insecure, because technically that is a shower of poor health and poor food access. So it's a very good question. We did not look at it in this because we were simply looking at kind of national data. But I don't think it's a bad idea to look and see if people who have a lower socioeconomic status do worse. What's interesting, though, is I would be curious to know if based on zip code and based on people's, how much money they make, how many people are getting these drugs versus not. And we're
That's
very
exactly
lucky.
what I'm thinking of too, because depending on a county ranking, you can kind of assess where they fall in the, the ladder.
What's access, but we're actually very lucky, and we've had a grant for many years with our medical bariatricians to help pay for some of these medications. So our data might be a little skewed, but it's a good question.
But then it can be a multi-center study.
Exactly. We'll call everybody in.
Yeah, absolutely. All right. With that, I think, thank you for this wonderful session. And this was a very, very interesting talk. Thank you, Dr. Nier, for summarizing everything. And I look forward to talking to you guys soon.
Thank you very much for having me. I appreciate it.
Absolutely. I'll see you guys later.